This is Susan Netterist. I'm Director of Graduate Medical Education at University Hospitals, and I'm thrilled to be here today with Timmy Sharma, who is one of our dermatology residency program graduates and currently the program director for the dermatology residency. So Timmy, welcome. And I
Thank you.
know you were associate program director for a while when you first took on a role in the program directorship in the dermatology department. What were you most excited about?
Hmm. You know, I really enjoyed my residency. Clearly I chose to stay. So I loved the program. I loved, I became good friends with a lot of my co-residents and with the faculty. And so I think I was just very excited to kind of give back and kind of um, further support the residents who were, my friends and further support, the department, which I loved and was very grateful to be a part of.
We are really fortunate here to have, so many specialists in almost every aspect of dermatology and be Midwest friendly, just like you said. I always tell the applicants that we really are as friendly and approachable, I think, as we appear to them, I hope, when we welcome them to their recruitment interviews.
Yeah, I agree. I mean, and I think that's actually a very common comment that we get, from our rotating medical students as well. Is just, wow, you guys are so kind. And I feel like, we could even be friends and lifelong, colleagues. And
Yeah, that's it.
yeah,
That.
exactly.
So now that you are program director, what are you most excited about now?
Oh gosh. Well, so I feel like I came on at a very interesting time. The first year that I started, I definitely had some ideas of what I wanted to do, and then lo and behold, it's COVID and pandemic, and it's just, it was like the rug was pulled out from underneath everybody, and it was just sort of like constant innovation out of necessity. And so now I think, we're at a very interesting time where we can kind of, thankfully the pandemic seems to be kind of easing up a bit, and we can kind of reflect on all these innovations that we've done and think about what was good, what was bad, what do we want to keep, what do we want to keep, pushing forward, what do we want to get rid of. And so I think just kind of being involved in all of that, like the forefront of all of that, it's really exciting for me.
Do you want to talk a little bit about the virtual rotations? I know you and another program graduate, Audrey Callahan, worked on that, and you presented that at a Association of Professors of Dermatology meeting nationally recently.
Yeah, so I think we were probably one of the first programs to throw together a virtual rotation that was actually, it's pretty robust and pretty involved. So we allow our rotating medical students to be in the clinic, either an iPad or virtually through a phone or some kind of electronic device. And they do virtual rounding on inpatient rounds, and they participate in, collecting data from the chart in chart review, looking up, related articles, and presenting the patients, really as if they're a strong member of the team. And I think, the students definitely really appreciated that. They told us that, that this rotation was probably the most robust, that they've done in the country, for an educational standpoint, and also just sort of being involved in the team and really getting to know us, the different residents, and getting to know the faculty. I think they really, really appreciated that. Actually, just thinking about it, our current incoming class, 5 out of the 6 med students that we matched actually did one of our rotations, so including our virtual rotation. So very, nice to see that that those students really enjoyed that experience and viewed it positively.
I think that's a great outcome metric that, so many people obviously valued the rotation. Great job. So as we approach, the next decade, of graduate medical education. And, ACGME has done scenario planning that says we need to figure out how to maximize competencies to work in teams, because physicians will mainly function in terms of patient care as master clinicians. So we have to figure out how they can supervise a team of advanced practice providers and artificial intelligence doing 80% of what physicians do now, and be able to swoop in at the master clinician level while they're also managing, quality improvement at the institutional and microenvironment level, right, in their own practice. That's a lot. So how are you, what are you thinking about that?
I guess I see that, I guess it almost feels like, at some point when we didn't have all of these lab tests and all of these different kinds of images that we now have, none of that was really part of the decision making or patient care. And it was, you just kind of go by the symptoms. Like, I'm just imagining sort of like the bedside doctor who, comes to the house and tries to figure out what's going on. And then now, and then at some point, then comes the X-ray and then the CAT scan and MRI and all this, all these extra tests that we now can utilize. And I think it's sort of part of the learning curve. These are now new things. Now we have to understand, their sensitivity, their specificity. How do we interpret all this stuff? It's going to be the same with AI, so it's going to have, I'm sure, some error rate. And so that is going to take some understanding and learning. And so I think it's going to be a slow process. I mean, I'm just sort of imagining every time, there's like a new, imaging technique or photo finder, a new thing that comes in. It's, I think it's scary to just sort of adopt it quickly without really totally understanding it. So, whatever new technology comes around, I think we'll just have to, very carefully inspect it and really, make sure we fully understand its limitations, how it can benefit us, how it can help with, certain things and maybe not others. So.
No, I think that's just the challenge for us, right? Is that artificial intelligence is just human behavior that's been, codified to take in a lot of data at once. But that 20% of what we're going to be increasingly doing as physicians has to be about taking targeted history and physical exam findings into account before we jump into the lab test. Otherwise, we're going to decrease the value of care, right? Because we're going to be spending a lot more money and arriving at a diagnosis much more slowly and less efficiently, which is really the value equation. So that's the hard part, is how do you teach very good diagnostic reasoning, meaning critical thinking, without spending as much time on the sort of bread and butter things that we also want to practice. And I'm not sure we've solved that yet, but in the end, it's going to probably require competency-based training, right? Where there'll be time variation because some people learn some of those skills more quickly than others. So that's our next challenge that I know you're engaged in. And we, talk about increasing the amount of workplace assessment to try to figure out where people are. I think it makes us better educators, but it's a big challenge. And I think that's what'll be exciting in the next decade. What else are you thinking about? What are the other challenges that you're looking forward to?
I think something that's been of particular interest to me is kind of what I was talking about before, like looking back at some of the innovations that we've had, because of the pandemic, and then just trying to see, what we can learn from this and what we want to continue, to use. So, for example, we basically flipped to virtual education, very quickly, because we needed to stay safe and distance, but we, residency and medical training needed to continue. We're still seeing patients and our residents need to still, be learning and stay competent. So, we flipped to virtual training, and I think it was just, we had a big question. Is this is this working? You know, is this something, are people still learning? You know, are we losing something by doing education virtually? Are we gaining something? Does this actually work better for some? And it's an interesting thought, because a lot of colleges and actually medical schools had already sort of flipped to a lot of technology virtual based education, but residency really hasn't done that yet. And so it'll be an interesting, learning point for us to find out if it is working for some and not for others, and why, and how can we use virtual education to supplement residency. So I know, for example, there's some things that work extremely well over virtual platforms. So like DermPath, I think both from the faculty perspective and from the learner perspective, everybody loves virtual DermPath, because you get this big screen, very clear image of what you're looking at. Someone can circle something for you, point out the exact finding, and that has worked very, very successfully. Other things, surgical techniques, not so much. So, some things, are working very well, and some things are not. So, being able to understand, those differences, I think it's just going to further enhance our curriculum going forward. Even when we are able to go back to live, we may choose to keep some things, in the technology realm. So.
Well, it was great speaking with you, and I'll continue to follow your career with interest and see all the cool things that you're doing with the dermatology program.
Thanks.